Yes.
I'm going to just call Dr. Tanno or send her a message and see if she wants me to get started. She may be running behind with patients, but I don't want anyone to have to wait. So let me just check, and if so, then I'll just get started.
Okay, sounds good. She just popped on, Dr. Council.
Oh.
There she is.
Hi, Dr. Tanno, how are you?
Hey, sorry about that, running a few minutes late here.
Oh, that's okay. That's what I figured. You were probably caught up with patients.
All right, well, looks like we have about, oh wow, the number, it's amazing how these numbers grow. We have about 40 people, so let's give people another few minutes to join.
Okay. How are you feeling today?
Just working from home, trying to fight off a cat who continuously tries to walk across my camera. You do one of these.
As you're talking to the patient, sorry.
But other than that, things are good here. All right, well, let me at least take a moment. I'm Dr. Tanno. I'm one of the primary care physicians at Rockville Internal Medicine, and I am coordinating these webinars. So again, as usual, thank you for joining in. If you have suggestions, you can email us. There's an email on the website to do that, or you can send it to the chat and I can just look at it now if you have any comments or suggestions. We appreciate you guys tuning in. And then Friday is so obviously we have Dr. Council today. I'll introduce her in a moment. But on Friday, we have Dr. Ira Berger. He's going to do some humor in medicine. So hopefully that is an enjoyable, funny, uplifting conversation. And anyone can join. I just got a question here. Is there a way for a friend to view some of the webinars? So yes, if you go to the Rockville Internal Medicine website on our homepage, we have a link to the COVID webinars. And there you can see, these are public. I don't think you guys need any, there's like a password, but I think it's posted on the website. So there's links to upcoming webinars and anyone can watch them. But also we have a YouTube channel, Rockville Internal Medicine Group on YouTube, where we are posting all of our recorded lectures. So if you have somebody who wants to join you, say for Friday, then they can get the link in advance. You can send it to them, or if they missed it and they want to watch it later, then they can see it on the YouTube page. And then also we have a Facebook page, which Dr. Holmes is one of our other new doctors. She is in charge of that. Dr. Holmes, do you think you could post that in the chat, the link to the Facebook page? So there's a lot of different ways to view this. And she said she'll put it on the chat. Okay. So like I said, Dr. Berger next week, that should be on Friday, that should be an uplifting chat for anyone. And then today we have a lovely conversation with Dr. Christina Council, who's one of our new primary care physicians at Rockville Internal Medicine. She joined us right in the beginning of this fiasco. I don't know how I would say it otherwise. So she actually, have you seen any patients face to face?
One, maybe, I think one.
So she joined us, what, in the beginning of March?
Yeah.
Okay. And she is trained in family medicine like myself. If you guys have more questions on that, you can ask her, I'm sure. But today she's going to do a helpful talk on preventative health. So I know there's been a lot of guideline changes in the last few years with mammograms and pap smears and prostate cancer screenings, and there's a lot of confusion out there about who should be getting screened when. So she wanted to do a lecture on that topic. And I guess we have about 50 people, so let's just go ahead and get started. And then I'm going to put the link to the Facebook page in the chat so that it's public if you guys want to look at it. But if you have any other questions, just put them either in the QA section, which is visible only to me and the other panelists, which are Dr. Council and Travis, who is our IT specialist, and then or you can put questions in the chat that are public. And feel free to ask questions throughout, and then we'll get to any at the end that we get through in the conversation. All right, Dr. Council, take it away.
All right, thank you. So as Dr. Tanno mentioned, I'm Dr. Christina Council, one of the new doctors here with Rockville Internal Medicine Group. And today I wanted to talk about preventive health in the adult population. So like she said, just, going over some of the screening recommendations, immunizations. So, oh, how do I go to the next one? Maybe I have to click it. Okay, so this is just an outline of some of the points that I want to address today. Like she said, if there are any questions, you can certainly ask in the middle of this presentation. So I'm first going to go over what exactly is preventive medicine, quickly go over the 3 levels of prevention, and then try to answer some questions you may have, such as how frequently should you be seeing your primary care doctor, and how do you know what screening tests you need, as well as going over some of the screening recommendations. So I'm going to talk about cardiovascular screening, cancer screenings, and then some other screenings like osteoporosis and fall risk. And then lastly, go over some of the immunizations that all adults should be having at this time. So what is preventive medicine? Preventive medicine is a field of medicine that uses the 3 levels of prevention, primary, secondary, and tertiary prevention, to focus on the health of the community as well as the health of each individual patient. The ultimate goal is to prevent disease and prolong life. So even for us here at Rockville Internal Medicine Group, we're not just focused on each patient as an individual, but also we're looking at our entire patient panel and looking to see how healthy are our patients and how can we help our Rockville, Potomac area become healthier. So quickly, what are the 3 levels of prevention? So primary prevention is a level of prevention that aims to prevent the onset of illness or injury. So these are going to be things such as immunizations, eating healthy, exercising, not smoking. I know that we had a talk by one of our nurse practitioners, El Shaddai, a few weeks ago where she talked about healthy eating and how that can reduce the risk of heart disease and cholesterol. So primary prevention is essentially preventing the onset of having any type of disease or illness. I included seatbelt laws here just as an example, a non-medical example of primary prevention. Secondary prevention essentially aims to reduce the impact of a disease. So it works to prevent the progression of a disease. Typically, this deals with screening tests, patients without symptoms. So we're talking about mammogram screenings for breast cancer, pap smear screening for cervical cancer, and colonoscopies to screen for colon cancer. The ultimate goal is to detect any cancer early enough so that the disease does not progress. Lastly, we have tertiary prevention, and this is something that we as primary care providers deal with pretty regularly, and that's because it really deals with chronic disease management. The goal of tertiary prevention is to reduce the consequences of an already established disease. So this is like diabetes management or hypertension management, that type of thing. So all of these levels of prevention are very important for primary care, and this is why we essentially ask patients to come in so that we can see them. So how frequently should you be having an appointment? It is recommended that all adults have an annual physical examination. And during that physical examination, of course, we're going to listen to your heart and lungs, but a good majority of the examination really has to do with these levels of prevention, primary, secondary, and tertiary prevention. So we're checking to make sure that the recommended immunizations for your age range are up to date. We're checking all of the screening tests to make sure that you've had your mammogram or pap smear or colonoscopy. We're also reviewing your current medications, making sure that it's up to date, and also making sure that you have the appropriate refills that are necessary. We're reviewing all blood work. And then also we do some counseling where we're talking about, weight management, exercising, making sure that you're having an appropriate, healthy and well-balanced diet, If you smoke, you may hear us multiple times tell you that you have to stop smoking. So the annual physical examination is really important for us to be able to address all of these preventive measures, as well as take a good listen to you and examine your body physically. But really the key is trying to promote prevention, which is why insurance companies cover 100% annual physical examinations. For those special populations, those patients that may have chronic medical issues such as high blood pressure, diabetes, depression, or any other chronic medical issues, the frequency of the appointment may vary. Sometimes we may want to see you every 3 months or every 6 months. It really depends on each individual patient and how well controlled some of these medical conditions are. So you may be wondering, well, how do you know what screenings you need? Or how do we know what are the best preventative services for you? So here in the United States, there is a task force known as the United States Preventative Services Task Force, or what we often say USPSTF. This is a task force that's made up mainly of primary care providers as well as preventive medicine specialists. And what they do is they review all the research on the various preventive services, and they provide evidence-based recommendations on when we should be having patients come in for screenings, preventive medications, and counseling. So the website for this I do have at the end of my slide if that's something that anyone wants to look at. So now I'm going to go into cardiovascular screening recommendations. So as I stated, every adult should have an annual physical examination. Each visit that anyone comes into the office, it is recommended that all adults have blood pressure monitoring at every single visit, whether it's your annual visit or your follow-up visit for a chronic medical condition. So if you don't have chronic medical conditions, then once a year blood pressure monitoring is absolutely fine. Cholesterol screening. So to be honest, there is some controversy on when we should start cholesterol screening. However, all primary care providers and most specialists will agree that there should be a baseline cholesterol screening whenever someone presents to a primary care office. So no matter what age someone presents, or I should say an adult presents, we will do a baseline cholesterol screening just to see where you are. For those adults who are low risk, and when I say low risk, I'm talking about those who may not have high blood pressure, no family history of early heart disease, no diabetes, healthy weight. For those adults, if they present before the age of 30, after we get that baseline, then typically we may do another cholesterol screening between the ages of 30 and 35. And from there, if cholesterol panel is completely normal, then typically we may repeat that within 3 to 5 years. If someone is higher risk, may be on cholesterol medication already, or have diabetes, high blood pressure, or any other risk factors for cardiovascular disease, then the lipid panel may be done more frequently. Diabetes screening. So the current recommendation is for any adult between the ages of 40 and 70 who may be overweight or obese, which medically is defined as a body mass index greater than or equal to 25, it is recommended that we screen for diabetes. Typically, we will screen with what we call a hemoglobin A1C, which is a blood test that tells us your average blood sugar over a 3-month period. All adults, no matter what the BMI may be, all adults who may have a history of high blood pressure or high cholesterol should have a diabetes screening. I will say that typically with the annual physical examination, we will include a comprehensive metabolic panel, which is a blood test that does include blood sugar. So we do check that annually. However, we'll include the hemoglobin A1C test for those individuals within that age range listed there who may have an elevated body mass index. So now I'm going to go into some of the cancer screening recommendations. I know this slide may be a little busy because this is a good chunk of a lot of the screening recommendations. So I'm going to start with the recommendations for both men and women, all adults. So currently for colon cancer screening, it is recommended that all adults start colon cancer screening at the age of 50. This excludes those who may be in that high risk category. When I say high risk, I'm talking about those adults who may have a family history of colon cancer, someone who may have any symptoms of GI abnormalities such as rectal bleeding, changes in their stool, or weight loss that they're not intending to lose weight. Those things, those individuals may start getting colon cancer screenings a little bit earlier. So like I said, at age 50, colon cancer screening is recommended for initiation. Now, there are 3 methods that are typically recommended for colon cancer screening. One is your traditional colonoscopy, the other is the Cologuard, and the third is FIT testing. I'm going to go a little bit into the Cologuard and FIT testing, just a little bit in case anyone is not familiar with that. So Cologuard is a stool test that is recommended for those individuals who are low risk for colon cancer. So once again, that's going to be for those individuals who do not have any GI concerns, in addition to those who do not have any family history of colon cancer. It is a stool test that should be done every 3 years. What happens is that a box is delivered to your home. You would collect the stool yourself and send it back to the laboratory to do the evaluation. What they are looking for when they evaluate the stool is they're specifically looking for any unseen or microscopic blood within the stool, in addition to looking at any DNA markers that may be associated with an increased risk for colon cancer. If a patient does have a Cologuard test done and it is returned positive, then we will recommend that you do the traditional colonoscopy. For those individuals who do a Cologuard screening at age 50 and it is negative, then we would repeat the Cologuard in 3 years. Colonoscopy frequency varies. If an individual does a colonoscopy at the age of 50 and the results are completely normal, no polyps, no concerns, typically the gastroenterologist will recommend for a repeat colonoscopy in 10 years. If there are any polyps or any other concerns, they may recommend that you have a colonoscopy more frequently. And so it may be every 5 years or every 3 years. The other test that I said for colon cancer screening is the FIT testing. That is also a stool test, which is looking for any microscopic blood or unseen blood within the stool. Because it does not look at the DNA markers as the Cologuard testing includes, typically the FIT testing is done every year as opposed to the Cologuard, which is done every 3 years. Lung cancer screening. Current recommendation for lung cancer screening is for any adult beginning at the age of 50 who is a current smoker and has a history of at least a 30-pack year history. When we say pack year history, 30-pack year history essentially is smoking 1 pack a day for 30 years or 2 packs a day for 15 years. So those who may have a 30-pack year history beginning at age 55, if they are a current smoker or have quit smoking within the last 15 years, it is recommended to get an annual lung cancer screening. And the way that we screen for lung cancer is with a low-dose CAT scan of the chest to check for any lung nodules or any abnormalities. Once again, that's done every year up until the age of 74 or 75. However, if an individual has quit smoking 20 years ago, 30 years ago, typically the recommendation is not to do the lung cancer screening. Now I'm going to talk about cancer screenings that are specific to women. Breast cancer screening. So now I'm talking about mammograms. Current recommendations by the United States Preventative Services Task Force is for all women to start breast cancer screenings with mammograms at the age of 50. However, it is also recommended that all providers start having that discussion with their patients at the age of 40. The reason why we start that discussion 10 years earlier is because we know that there are some risk factors that may put an individual woman at increased risk for breast cancer, such as genetics or exposure to estrogen, smoking history. And so for those individuals, we typically will engage in what we call shared decision making, talking with the patient and doing a risk benefit analysis to determine if that is someone who should start breast cancer screening at the age of 40. I do want to note that the American Cancer Society still recommends that women get annual breast cancer screenings starting at the age of 40. So there is a little bit of variance with the United States Preventative Services Task Force and what some of the other medical societies recommend. Because of this, most insurance carriers will still cover to have an annual breast cancer screening with a mammogram beginning at the age of 40. Cervical cancer screening for women. So Pap smears are recommended for all women beginning at the age of 21. Women ages 21 to 29 should have a Pap smear every 3 years without HPV testing. And I know that this is a little different. Not several, but maybe about 10 years ago, the recommendation was that you should get a Pap smear every single year. We still do recommend that you have an annual physical examination, like I mentioned earlier. Those women who may see a gynecologist, it's still recommended to have an annual well woman examination, which is essentially an examination where the provider will look at the cervix, will, feel your uterus and make sure everything feels fine. However, the Pap smear recommendations have changed, and now it is recommended 21 to 29 Pap smear every 3 years. For those women aged 30 to 65, the recommendation is to have a Pap smear every 3 to 5 years. Women ages 30 to 65, if you are having a Pap smear every 3 years, then typically we will do a Pap smear without HPV testing. Excuse me. For those who may want to space out their Pap smears, then it is fine to go every 5 years, and we will do a Pap smear with HPV testing. Now, I do want to state that in regards to all of these cancer screenings, colon cancer, lung cancer, breast cancer, and cervical cancer, you do see that I have these age ranges that, for a breast cancer up to age 74, cervical cancer 65, colon cancer 75, and lung cancer 74. I do want to emphasize that although this is the recommended age, once again, it is shared decision-making between the provider and the patient. The reason why we have these cutoffs is because we have to determine whether or not the risks of a test outweigh the benefits. And so if we found a breast cancer in an 85-year-old woman who may have other chronic medical conditions, then sometimes it may be reasonable to say, let's manage the chronic medical conditions and not put this elderly individual through, mastectomy and any type of cancer therapy and things of that sort, if it is expected that they may pass from another illness prior to the cancer. So this is why we say shared decision making. It is not a definite that at 74, you don't need a mammogram any longer. For those that want to continue getting mammograms or Pap smears or colonoscopies, then that's absolutely fine. But that's something that I recommend that all patients discuss with their providers so that we can go over your individual case and determine if it makes sense for you to continue with screening. Lastly, I want to talk about prostate cancer screening recommendations. So at this time, it is recommended that all providers have a discussion with men beginning at the age of 50 regarding prostate cancer screening. And when I am talking about prostate cancer screening, I'm specifically talking about PSA blood testing. And for those that are high risk, that discussion should start a little bit earlier, typically around the age of 40. Once again, those that are considered high risk are those that may have a family history of prostate cancer, as well as African American men. So there are no specific guidelines on the frequency of doing PSA testing. And the reason why it says a discussion as opposed to doing PSA testing is because, once again, we have to go through a risk-benefit analysis. PSA is not a test that is specifically for prostate cancer. So a male may have an elevated PSA not related to prostate cancer. And so because of this, we have to do a risk-benefit analysis to determine whether it's reasonable to check a PSA on an individual. And that is because some studies have found that when we do PSAs, and if it is elevated, then there may be the unnecessary anxiety that is put onto a patient thinking that they may have a prostate cancer, in addition to unnecessary biopsies and things of that sort. So typically, starting at age 50, we will go through that discussion and talk about the benefits and the risks of doing PSA screenings for African American men. And for those who may have a family history, we start that discussion at 40. And if patients agree, then we will certainly go forward with ordering the PSA testing. So what are some other important screenings that are recommended at this time for adults? Osteoporosis screening. This is recommended for all women ages 65 and above. And the way that we screen for osteoporosis is with a bone density scan, or what we call a DEXA scan. There are currently no recommendations for men to have osteoporosis screening. However, that is also something that can be discussed, and we can engage in shared decision-making with men who may be on chronic steroids or may have had fractures or frequent falls or things of that sort. The last screening I want to discuss is fall prevention screening. So as I mentioned, an annual physical examination is recommended for all adults. For those adults age 65 and above, it is recommended that you get a Medicare annual wellness visit. The Medicare annual wellness visit is a visit that is covered by Medicare 100%, in which we go through all of these screenings as well as the other preventive measures that I had mentioned earlier. During the annual wellness visit, we also will do a fall prevention screening, where we essentially are asking, have you had any falls within the last year? Are you walking with a cane? Do you feel that your gait has been off? Are you needing to hold onto furniture to get around your home? All of those different questions are important. For those adults who may screen positive and have issues with falls or with not feeling steady with their balance, sometimes we will refer you to physical therapy to help with your gait and balance. Lastly, I'm going to talk about the immunization recommendations for adults. So I know sometimes we think that immunizations are for children. However, there are some vaccines that are recommended for all adults. The first vaccine is the pneumococcal or pneumonia vaccine. Current recommendation is that all adults age 65 get the pneumococcal vaccine. It is a 2-dose vaccine. At the age of 65, it is recommended that adults receive the 13 series pneumonia vaccine. 1 year later, it is recommended that adults receive the 23 series pneumonia vaccine. For those adults who are under the age of 65, but may have chronic medical conditions such as diabetes, asthma, or those who are smokers, it is recommended to get 1 dose of the pneumonia vaccine before the age of 65. I will say that again. For those adults who have chronic medical conditions such as diabetes, asthma, or those who smoke, it is recommended that you receive 1 dose of the pneumonia vaccine before the age of 65. You will then need the 13 series pneumonia vaccine at the age of 65, as well as receive the 23 series vaccine 1 year later. Recommended immunizations: shingles or the Shingrix vaccine. the started age for that vaccine is the age of 50. This is a 2-dose vaccine. First dose should be administered at the age of 50, and the second dose between 2 and 6 months after that. For those of you that may have received the old shingles vaccine, the Zostavax, it is recommended that you now receive the Shingrix or shingles vaccine series. For those that may have already had shingles but did not receive shingles vaccine, it is recommended that you do receive the shingles vaccine. Having shingles does not exclude you from needing the shingles vaccine. Next vaccine is the influenza or flu vaccine. It is recommended that all adults receive this vaccine annually. And the last vaccine is the Tdap or TD, which is our tetanus vaccine. It is recommended that all adults receive 1 dose of Tdap, and then 10 years later, receive a booster of the Tdap or TD vaccine. And that should be done every 10 years. These are my references, and that is it for these screening recommendations.
All right, thank you. What is the most common question, Dr. Council, you think what's the most common topic that you get questions on from patients?
Probably, do I really need to come in every year? And yes, you should come in every year. The other question I commonly get is why the change with the Pap smears? Previously, I was getting Paps every year, and now you're saying I don't need it, for 3 years or 5 years. Some patients feel uncomfortable with that, which is why it's still recommended to have an annual women's examination. However, the Pap smear is not recommended every year.
Okay, so we have some questions coming in, so please submit them as we have plenty of time. So anything you've been itching to ask us, please ask. So one person asked, what about going over gun safety with patients? What's your current methodology with that? You may have done that more with when you were seeing children, but
I was going to say with pediatric populations, definitely that's something that I talk more about. However, with the counseling that's done during the annual physical examination, definitely, I may ask, do you have any guns in the home? Where do you keep the guns? Are they secure and locked away? That type of thing.
Okay. And then there's a question here. I think they're referring to specifically to colon cancer screening. And I just want to let everyone know, we're going to have some of our GI doctors are probably going to do whole webinars and likely cover colon cancer screening in more detail, because for a lot of people, that is probably the most anxiety provoking of the screening tests. But the question asks, what is the record for false positive and negatives with some of the testing? Dr. Council, I actually was looking that up while you were talking, so I figure you don't know the numbers off the top of your head, but if you know something off the top of your head.
I don't know the exact number. Do you know the exact number? You can tell me.
That's okay. That's what I figured. So in terms of the exact, these are the numbers. So this is, like I said, we'll have some of the GI doctors weigh in, because I don't want to give anyone a whole lot of false information, because a lot of these numbers they're skewed. I mean, this is a private company that makes Cologuard, that is the stool cancer test that Dr. Council talked about. So essentially, Cologuard is a home test you do. It's very good at detecting advanced cancers. That's where it's very good at. It's about 92% sensitive in finding advanced cancers. It's not so good with the precancerous lesions that are not cancerous and are small. So that's where colonoscopy has advantages, that a colonoscopy is not only diagnostic, but it's also therapeutic, which means they can find a little polyp and actually remove it before it grows into anything. The downside, I'd say, with Cologuard specifically, is that there's a higher false positive rate, which in some ways is by design, because they don't want to miss anything with that. And so the numbers that they have on their website, they say that there is a 13% false positive rate, which means you get a test that shows that potentially you might have some colon cancer, or you might have some blood in your stool. And so that those people will all end up, if they consent, going for colonoscopy. So it adds a lot of anxiety to some people. And then it has about an 8% false negative rate, meaning that it tells you that you have nothing and you might actually have something. So again, like I said, we're going to have a whole conversation with our gastro doctors, and they can go much more into that data for you, because I'm sure that a lot of you are asking questions. But these are also the conversations you would have with when you meet with that gastro doctor the first time to talk about colon cancer screening. You would talk about your risk factors and your symptoms and your family history, and they can go over some of those specific data, that information. You know, this is what they do all day, every day, and they can, you know, alleviate some of your anxieties and talk to you about what the best test is for you. All right, other questions here. What is the time schedule for fall vaccines, assuming the practice is open as normal in the near future? So I think you're talking for fall vaccines. I assume you're talking, this patient is talking about the flu.
Right, right. So typically, you start getting your flu vaccine, you know, sometime September, October time. So assuming that we're open at that time, we will have a batch of the flu vaccines, and we'll definitely be pushing for all patients to be vaccinated.
And right now we are doing drive-by vaccines. So if you know you're due, say, for a pneumonia vaccine or a tetanus vaccine, what I'm having patients do is call the office, it's called a medical assistant appointment, and just so they know you're coming. And we're doing drive-by vaccines. So you come at a certain time, and then you call when you're outside to let them know that you're in fact there. And then the medical assistant, who has been hopefully expecting you, comes out and does your vaccine. So I'm not sure how the flu would work if we're still in a virtual world, but I imagine it would be the same thing. But we would definitely want everyone to get vaccinated for flu, no matter what scenario is going on. All right, we have a lot of questions here. Okay, I'm gonna start going through them, because otherwise I'm getting distracted. Pap smears after hysterectomy. You want to talk about that?
Yes. So it depends on why an individual had a hysterectomy. If the hysterectomy was for concern for any type of cancer, precancerous abnormalities, then the recommendation is that we still do a pap smear and try to swab that vaginal cuff. For those that may have had a hysterectomy due to heavy bleeding, or just because they didn't want any more children and they said, I just want you to take the entire thing out, then the recommendation is, as long as you've had normal screening and have not had any abnormal pap smears, you can stop having pap smears. So with pap smears, we're swabbing the cervix. With a hysterectomy, the cervix has been removed. However, for those, like I said, who may have had any concern for cervical cancer, or may have had any concern for uterine cancer, then it is recommended that we still swab just that vaginal cuff, the area that has been sewn up from where the cervix was.
And then sometimes, just thinking about this, sometimes women have had a hysterectomy after for a lot of for prolapse, and sometimes they actually will leave the cervix in for a little additional support. So if you had a hysterectomy, your doctor will talk to you about this, because as Dr. Council said, sometimes you still do need a pap smear after hysterectomy. It depends on the
type. Yeah. So I typically, with patients that may say, oh, I've had hysterectomy, I'll ask, you know, do you know if you have your cervix or not? And most patients will say, I have no idea. And so I may look and say, no, you don't, or actually you do have a cervix. So you do still need to get pap smears.
Yeah. All right, coming back to some colon cancer questions. Should I be concerned if I've had colonoscopies but never had a stool test?
No. So the recommendation is to do one of those 3 colon cancer screenings. Colonoscopy is the gold standard. It's the best one because we're getting into that colon and actually looking at the actual colon to see, like Dr. Tanno said, are there any smaller polyps there or any abnormalities, anything of concern. With the stool testing, that is an alternative for those individuals who do not want to do the colonoscopy. The main issue with colonoscopy is that people do not like to deal with the prep. You're trying to clean out your bowel completely. So you're going to be running to the bathroom a lot. That is probably the worst part of the colonoscopy. In addition to the fact that you will need to have someone go with you when you go get the colonoscopy. So sometimes patients say, I don't have anyone that can sit while I get my colonoscopy and drive me home. And sometimes patients say, I just don't want to have to go through that prep. It was horrible, whatever it may be. And so that's why there are these alternative measures. However, the colonoscopy is the gold standard. So we typically try to recommend that you get a colonoscopy. For those that really do not want the colonoscopy, then we have these other options available.
Okay. Patient says, I'm 75, just as some background. How often should I be getting a bone density test?
So now it depends also on what your previous bone density results were. If you had osteoporosis or osteopenia, or if it was completely normal. So currently there are no scheduled frequency recommendations. However, typically as primary care providers, we will repeat a bone density examination between 2 and 3 years to follow up and see how things are going.
And then a similar question is, I just lost it. Well, not similar question, sorry, unrelated question. You already talked about this during your presentation, but maybe you could recap. When can I stop getting mammograms?
So the current recommendation is that at the age of 74, women can stop getting mammograms. But once again, like I was saying earlier, is that these are not strong cutoff dates. Now, if someone is 75 and says, I'm done, I don't want any more mammograms, then that's absolutely fine. However, if you're 75 and you say, no, I want to get a mammogram, then we're not going to say, oh no, it said 74, that's it, you can't get a mammogram. It's absolutely fine to continue getting it. So that's something that you discuss with your provider. However, current recommendations are up to the age of 74. I will say that my grandmother is over the age of 90 and still gets mammograms.
Yeah, and it's a conversation to have with your doctor. I think a lot of times, the question is, if they were to find something on the mammogram, would you do something about it? And if the answer is no, then a lot of times I would stop screening. So for your 90-year-olds who say, oh gosh, no, I would never have surgery or any kind of treatment, then why bother?
Why are we looking? Exactly.
Yeah. But then you have the patients who say, I don't know, it depends on what it shows. In that case, then you say, well, then maybe continue screening. So again, these cutoffs are suggestions, and then it's conversations with your doctor.
Exactly.
This is a similar question. I'm over the age of 75 and was hoping to never have another colonoscopy.
Well, then we know the answer there. If you are over the age of 75 and you do not want a colonoscopy, and if we were to say, hey, if we did find a polyp or we did find something that looked like it was cancerous, would you want to go through, having a partial or full colon resection and all of those other things that may come with it? And you say, no, absolutely not. I'm over 75. I'm not going through that. Then there's no need for us to continue screening for colon cancer.
A patient says, I have a primary care physician at Rockville Internal Medicine. Is that sufficient for preventive care, or do I need to have any specialists?
Nope, that is absolutely fine. So that is what we do. That is our bread and butter, is for primary care providers, is any type of preventive medicine, as well as chronic disease management.
Yeah, so I think in this area, a lot of patients, compared to other places I've practiced, a lot of patients do have a gynecologist.
Mm-hmm.
And so a lot of times, what I say with those patients is, if you have a long-standing relationship with that person and you want to continue them, then great. But if somebody is, say, new to the area and doesn't have a gynecologist, I do pap smears, Dr. Council does pap smears, we do breast exams, we order mammograms. Obviously, if something is grossly abnormal, then we would refer as needed to the specialist. But she's absolutely right. And if your primary care physician at the practice is a man and either doesn't do pap smears or you don't feel comfortable with them doing pap smears or mammograms or breast exams, then all of our nurse practitioners do them. Kimberly Nieves, who gave a lecture last week on menopause, you know, a lot of the male doctors will refer their patients to her specifically for their female preventative care. So yes, you can keep it all in-house, as we would say. Okay, so questions about us having the shingles vaccine on hand in the fall. So I guess there's a longer question here. So is it protocol to receive pneumonia and shingles vaccines during the same time period in the fall as with the flu shot? And then, so maybe Dr. Council, you can answer that question if there's any timing of those seasonally.
So you can get you don't have to wait until the fall to get pneumonia or shingles or anything. Flu is a seasonal vaccine, so it's only available, it starts becoming available in the fall. So that's something that, yes, you will get in the fall. However, like Dr. Tanno said earlier, if you are due for a shingles vaccine or pneumonia vaccine, that is not something you need to wait until the fall to get. You can get that now. I think, am I answering the question?
Yes, and then as far as the shingles vaccine, since Dr. Council was not with us last fall, let me just say, there is a national shortage of the new shingles vaccine, the Shingrix vaccine. As a result, we did not have it. And also we found that Medicare was covering it as a pharmacy benefit, not a medical benefit, which is so stupid because everyone should be getting vaccinated no matter where you get it. But essentially what that meant was we didn't have it in our office. You had to get it at the pharmacy. And even if we did have it in our office, we'd probably recommend that Medicare patients get it at the pharmacy so that it's covered by insurance. So basically, long way of saying we don't have it. We still don't have it. If we get it, I'm sure that we will offer it, you know, as liberally as we can. And so normally I would refer you to go to the pharmacy to get your shingles vaccine. But right now, with COVID and having people stay home, if you happen to be in a pharmacy and they have it, great, but I wouldn't necessarily make a special trip for it.
Agreed.
So patient asked about, I think so the question is there ever a time you would request a DEXA scan from me? So I think this is maybe a question that refers to when do we start DEXA scans?
So DEXA scans are recommended for women beginning at the age of 65. However, if there is an individual who is high risk, someone who's been on chronic steroids, someone who's had, you know, a fracture from a fall that we wouldn't expect for you to have a hip fracture. For example, you know, I tripped and fell off the curb and I fractured my hip. Well, that's, you know, not something where we'd expect that you would fracture your hip from a small fall like that. So that gives us, you know, high suspicion that your bone density may be a little lower. So things of that sort, we may order a bone density scan or DEXA scan earlier than the age of 65. However, it's recommended to start the bone density scan for women at age 65. But once again, if you're high risk for any of these screening recommendations, then it may be done earlier.
And I will say the best time to talk about all of these preventative care studies is during your physical or your Medicare wellness visit. I have a lot of patients who come in, you know, they come in 6 times a year for diabetes and high blood pressure and all of this stuff. And you just, in one visit, you can't cover everything. So I think if you're sitting here thinking, gosh, no one's even asked me about my preventative care. My first question to you would be, well, have you had a preventative care visit? Because, you know, we, as doctors, we have, you know, so much time with each patient. And so it helps us to have the visit be focused on, you know, one task at hand. So if you have questions about your specific screenings, make sure that you have had a physical in the last year. And then if not, bring it up at the next physical. Okay, question here. Does the U.S. Preventative Task Force address ethnic variations in prevention screenings, specifically for the African American population?
So like I was saying earlier, for the PSA screening, because African American men are at high risk for prostate cancer, mortality and morbidity, it is recommended that that discussion regarding PSA screening is started earlier, typically the age of 40 for African American men, as opposed to the age of 50 for Caucasian American men. So it does take that into consideration. For all of these other screening recommendations, colon cancer, lung cancer, breast cancer, cervical cancer, there are no specific recommendations for African Americans, and a lot of that is because we're not seeing that there's necessarily a higher risk associated with it. An individual may have a higher risk of any of these cancers due to family history, which is why we get the family history and we try to find out, hey, if you had an uncle who had colon cancer and a cousin, at what age did they get colon cancer? And so that is why we say, shared decision making or a conversation with your primary care provider to figure out, are you considered individually, no matter what your race is, are you at higher risk for some of these other cancers? And if so, then we may start that screening a little bit earlier.
Okay. And then I think you talked about this a little bit also, but a patient just wanted further clarification on the difference between a Medicare wellness visit and an annual physical exam.
Okay. So the Medicare wellness visit is only for Medicare recipients. So those are going to be our adults age 65 and older who have Medicare. That is going to be, Medicare specifically designs it as a conversation. Essentially, we sit down and we go through all of these screenings. Of course, during the Medicare wellness visit, we weigh, take a listen to your heart and lungs. However, with a Medicare annual or wellness visit, they are not expecting the provider to actually physically examine you. It is really a conversation to go through all of your health screenings. The annual physical examination goes through all of those things, as well as do the head to toe physical examination. Medicare, from my understanding, and Dr. Tanno, you may know better than I do, Medicare, some Medicare companies, I guess, do not actually cover a physical examination. They cover the Medicare annual wellness visit, but an actual physical examination that a non-Medicare recipient may get is not covered under Medicare.
Yeah, so I think the way we kind of handle it in our practice is they're scheduled the same way as if basically your physical exam for the year. And then if it's a regular physical exam, we would go through, I say regular, but your annual physical exam, if you're say 50 years old, it's your regular, go through all these preventative screening tests, do your full physical exam, heart, lungs, breast, abdomen, pap, all of that that's needed. And then depending on your chronic medical conditions, your high blood pressure, diabetes, we might go through that at that same visit. Again, it can be a lot for one visit, so sometimes it's divided into two visits. This can be confusing to patients because the preventative portion of that, the physical exam wellness portion of that is covered by your insurance as a preventative visit, and therefore there isn't a charge. But if we go through additional problems like your cholesterol and your, cholesterol will be preventative, but if we go through your blood pressure and your diabetes and your, multiple sclerosis and other things, then you might actually get a bill for that second. It's essentially like two visits billed into one is how it is. And the Medicare wellness visit is the same thing, where a lot of us will still do the full physical because you're there. But then we also go through all the list of the Medicare preventative questions, as Dr. Council said. And then if we are able to do in one visit, we would also go through your chronic medical problems and medications and all of that too. In which case you might also, again, be billed essentially for two visits in one. You're always welcome to divide them up into two separate visits if you want just one, preventative care visit and one chronic care visit. But that is how we sort of structure them in our practice. So I think in our practice, the two would look very, very, very similar, but it's more like a billing thing in the background.
Thing than anything, right?
Yeah, and then also in the Medicare wellness, some of the preventative questions, like Dr. Council said, it's a little more strange. Like we'll ask you about your hearing and your vision and your fall risk. It's a little bit more Medicare tailored. So sometimes there's questions there that you might be sort of like, that's an odd question. I've never been asked that before. All right. So what is a Tdap?
Tetanus, diphtheria, and pertussis. It is your tetanus vaccine. So it is recommended that all adults receive at least one dose of the Tdap, the one that has pertussis in it. Pertussis is whooping cough. And so adults are typically the carriers of whooping cough, but children are the ones that typically get the illness. And so that's why it's recommended that all adults at least receive one Tdap, and every 10 years afterwards, just get the TD tetanus booster.
Yeah, okay. I just want to let people know that we have a lot of questions that have come in here right at the end that I don't think we're going to get to. So if you had a question about specifically like Prolia, there's a question here. I would say refer to your primary care doctor. Prolia is a bone density osteoporosis medication. Somebody else asked about some side effects of some medications. Again, I would refer you to your primary care doctor so they can look at your chart and know you and answer. Okay. And let's see. I'm trying to see if there's another quick question that maybe we can get to. Are you currently doing physical exams? And how much advanced time is needed for scheduling?
Yes, we are doing physical examinations via virtual visits. Typically, we're scheduling them, we need typically 30 to 45 minutes. To get out of this, sorry.
And so normally for an inpatient visit, most of the primary care doctors, since we only do so many of these visits in one day, it does take about 2 to 3 months to get on the schedule. So in regular times, like if you wanted a physical with me and you called today, you probably wouldn't get one until either the end of July or August. And that's pretty typical for most primary care doctors in this area. That being said, if you had if you wanted your blood pressure check or an urgent issue, then usually you can get that within, within a much more reasonable amount of time, a week or two, very rarely longer if something else is going on. And then as far as the virtual visit physicals, which sound crazy, but at least it's an opportunity to run this list of all this preventative care. Those are pretty, our schedules are pretty open right now. So you could probably call and get one with your doctor, with
same week or so.
With not even the same day. I mean, really, it's an open schedule.
Yeah, I did get a private question. Someone asked if I ever have patients who don't know if they have had an annual physical examination. I will say that sometimes patients may not know just because they may think, okay, I just scheduled a visit and I don't know. But if you don't know, then you can always call and say, hey, when was my last physical examination? We can look in your chart and see the last time a physical examination was done and let you know. And like I said, it's done annually. So if your last one was May 1st of 2019, then you're due to get one, as of May 2nd, 2020.
Yeah. So a good Samaritan among you wanted me to remind everyone that the webinars, that if these webinars bring up issues that you are alarmed over, talk to your doctor at RIMG, you're in good hands. So yes, I think remember we are here, we're doing virtual visits. This morning, I think I had like 8 openings on my schedule. By lunchtime, most of them were filled. So we have a lot of openings right now. You're happy to do virtual visits. If you have questions, if you're confused, if you have a medication that you're not sure if you should still be taking, if you don't know if you have had a DEXA or a mammogram or any of those things, go ahead and schedule. We're here, and we're here to help you. So for those of you who submitted more personal questions, or if we just didn't get to your question, feel free to talk to your primary care doctor, make an appointment. And then our specialists are also here, and they are also doing virtual visits and taking appointments. But I think that's all we have time for today. So just remember, Friday, Dr. Berger is going to talk about humor in medicine. So that should be a good one. And then thank you very much to Dr. Council for putting this talk together. It was very thorough. She referred you guys to a lot of really good websites and sources as well, where we get these guidelines from. And then I think next week, I'll talk about next week's lectures on Fridays because I think we're running out of time. But Thank you everyone for joining us. Dr. Council, do you have any last parting wishes for anyone?
No, that's it. If you did not get a chance to get to your question, please schedule an appointment with myself or any of the other providers at internal medicine. We'll be happy to answer them.
All right, thank you everyone. Have a great Wednesday.
All right, thank you. Bye.
Bye.